Hello and welcome. In this lecture, we'll be considering behavior change interventions alongside associated framework, theory, and examples. The learning outcomes are to understand selected frameworks and models that can guide behavior change interventions in health and care settings. Also, to describe selected theories that address information system success and failure in health and social care. And finally, to critically evaluate a practical application of behavior change theory in a real-world example. As an outline, we shall examine the behavior change wheel framework, the information value change theory, and how the framework and theory were used or tested in the real world. Do they really work? We shall be considering these points in more depth in the following slides. In general, behavior patterns are measured in terms of the prevalence or incidence of particular behaviors in specified populations. For example, delivery of smoking cessation advice by general practitioners. Now, as a definition by Michi and colleagues in 2011, behavior change interventions can be defined as coordinated sets of activities designed to change specified behavior patterns. Improving implementation depends on changing the behavior of professionals, managers, commissioners, and others working within and with the health and care system. To consider the usefulness criteria for behavioral change intervention frameworks, three factors are important. Number one, comprehensive coverage. The framework should apply to every intervention that has been or could be developed. Failure to do this limits the scope of the system to offer options for intervention designers that may be effective. And the other factor is coherence. Now, categories are all exemplars of the same type and specificity of entity. And the third factor is the link or links to an overarching model of behavior. Now, the term model was used in the sense as defined by Oxford English Dictionary as a hypothetical description of a complex entity or process. Now, for the overarching model of behavior, we started with motivation, and this motivation is defined as brain processes that energize and direct behavior. Now, this is a much broader conceptualization than appears in many discourses, covering, as it does, basic drives and automatic processes, as well as choice and intention. Moving on to the behavior change wheel. Now, the behavior change wheel is a psychological method for describing and designing behavior change interventions. Explanation of behavior change wheel core behavior system has the three essential conditions, which is dubbed or called the COM-B. Now, this COM-B model, COMB model, forms the hub of the behavior change wheel framework. It is surrounded by 9 interventions, which is the second layer in red and different colors, and also with 7 categories in which they operate. We'll be looking more into this as an example. The COM-B system, or the COM-B model. So the behavior occurs as an interaction between 3 necessary conditions. And these conditions are the capability, opportunity, and motivation. So this is a way of understanding behavior. Now, psychology and the capability element of it refers to psychological or physical ability to enact the behavior, while the motivation refers to reflective and automatic mechanisms that activate or inhibit the behavior. And the opportunity is the physical and social environment that enables the behavior. This is a COM-B example. The Clean Hands campaign was launched to reduce specific infections in hospitals in England and Wales between 2004 and 2011. This was led by Sheldon Stone. To influence behavior among healthcare workers, the opportunity element of the COM-B model was the presence of alcohol hand rub beside every bed. The motivation was having persuasive posters around hospitals and encouraging patients to remind healthcare workers to clean their hands. With the capability component, there was no intervention. You would wonder that nurses have the capability to clean their hands, so do all healthcare workers, but not to pay attention to this behavior over other competing behaviors. There are other things the healthcare workers do within their workplaces. And also, the nurses did not develop routines for noticing when the behavior does not occur and plans for acting in future. Now, how do we go about this using the behavior change wheel matrix? The COM-B element that needed to increase was the capability side, in particular, the psychological capability. Now, the intervention functions were applied to this gap, or this aspect that needs to be filled up, or that needs to be addressed. And the 3 functions, intervention functions that were used from the behavioral change wheel framework was education, training, and enablement. Now, the staff were trained to set goals and make action plans. And also, they were enabled by observing their behavior and give feedback and support development of action plans. Now, all of this was informed by a behavioral theory called the control theory. Another example of the behavioral change wheel is where this framework informed the design and development of an app called the Particip Action. The implementation was carried out by True Love and colleagues in 2020 and was funded by the Canadian government. 3 stages were involved and they were considered in designing the app. They include comprehending what the problem and the user preferences were, and embedding the research findings into the app functions, and also identifying the app content and implementation options. Now, the study in question adopted the key sub-steps for each stage. For example, in stage 1, the problem is defined in behavioral terms, which related to a serious public health problem of physical inactivity among most Canadian adults. In stage 2, a total of 6 out of the 9 possible intervention functions were selected, including education, persuasion, incentivization, training, environmental restructuring, and enablement, which are the intervention functions. Now, in stage 3, main behavior change techniques were selected for the app, and they include goals and planning, feedback and monitoring, barrier identification, action planning, and shaping knowledge. Specifically to the COM-B example, the behavioral analysis and diagnosis step reviewed barriers and facilitators to the target behavior in all 3 components of the COM-B core. It went further to specify what needs to happen for the target behavior to occur and the need for a change. The study reports that over 1/3 of Canadians currently track their physical activity level and number of steps, with 41% using smartphones and apps to do so. Additionally, participants indicated they would be more likely to interact with the app and change their target behavior if the app summarized their data and progress over time, included a physical activity or step counter, and provided the opportunity to earn rewards. Having considered the behavior change wheel framework and its applications, we will move on to consider the evaluation theory. There are 2 basic goals when evaluating any information or communication system. Firstly, the evaluation must help determine if a system is fit for purpose or its efficacy. Does it do what it is meant to do? Secondly, we may want to decide if a system is the best choice amongst alternatives when used to solve a problem in the real world. What is it that the relative effectiveness, or what is the relative effectiveness? I beg your pardon. So, which solution should we pick in all of this? Information value chain theory provides a straightforward approach to both system design and evaluation. With its foundation in classical decision science, it provides a mechanism to tease out or tease apart the different benefits that might be associated with the use of a given information technology, and also helps to identify why expected benefits may not be detectable. The chain typically begins with a user interacting with the system, which is the interaction box. Some, but not all of these interactions potentially provide information that is then received by a user, that is the information received box. Some of this information may lead to a decision being changed, which is the decision changed, and sometimes leading to a change in the process of care. This is where the care process is altered. And finally, some of these process changes may then impact the outcome for a patient. And this is the outcome changed box. The profile of expected utility for an intervention will vary across the steps of the information value chain, depending on the primary purpose of the system. And we can see this from Correra 2015. A decision support system would be designed specifically to improve decision making and outcomes, while an EHR is typically designed to improve record keeping, and process improvement goals are reserved for other functions. From the diagram, we can thus imagine different systems having different quiet profiles for the expected utility at different stages of the information value. Again, the hypothetical utility profiles are presented for 4 different classes of informatics intervention. Now, from the diagram, we would see that they illustrate that an intervention may be changed, or may be designed to provide value by improving the quality of interactions in a health service, but may provide little additional information compared to current practice. And that is the case of teleconsultation. As for EHR intervention, it may optimize the quality of information capture. For care pathways, an intervention may be designed to improve the quality and efficiency of clinical processes. And an intervention may also be intended to intervene in the decision-making process to improve clinical outcomes. And that relates to the decision support system. Now, some downstream benefits may even incur an upstream cost. For example, interacting with some EHRs requires more time than normal practice. The actual benefit of these intervention classes may be very different depending on the specific bundle of services offered. For example, it is likely a system that bundles together EHR and decision support will have higher utility than each system alone. In this case study, the information value chain provides a simple causal model connecting EHR use and clinical outcomes. Each step is characterized by different measures and is dependent on different elements of shared record system design and use. So that is adapted from Bowden and Correa 2017. For any formal evaluation of an electronic record system, EHR in this case, whether at a single institution or a national scale, measurements need to be taken at multiple points along the value chain. The outcome at any stage can only be understood by modeling earlier upstream events. Thus, failure to demonstrate clinical outcome changes following the implementation of an EHR might arise because of problems with events early in the chain. For example, record quality. Alternatively, a lack of impact on outcomes may be unrelated to the EHR. For example, organizational challenges may prevent important information from the EHR being translated into process changes. Let's now move on to consider a real-world example where behavior change interventions were implemented. And thanks to Professor Robbie Foy and the Aspire program team for making this available. There was a range of complexity in the study, and they include multimorbidities among 23% primary care patients. And out of these primary care patients, they had 82% aged 85 years and above. Also, part of the complexity was multiplying top-down priorities and guidelines. And over 100 of these were relevant to the GP. Also, there was multiple bottom-up priorities. For example, 2.5 problems per 11.9 minutes. And also they were multiplying demands, multiple disorganization. And we could see that from the image. The Aspire program team carried out a cross-sectional analysis of routinely collected electronic primary care data from a sample of general practices in West Yorkshire in the UK. And this was about 89 of them. They developed a set of evidence-based high-impact quality indicators for primary care and examined variations in achievement of these indicators using routinely collected data in the United Kingdom. Now, the 4 quality indicators comprise of diabetes control, blood pressure control, anticoagulation for stroke prevention in patients with atrial fibrillation and risky prescribing. Again, they studied the adherence to these quality indicators quantitatively, as we can see from the charts. And these formed the basis for another qualitative study. Lawton and colleagues developed an adaptable implementation package, which comprised of interviews with health professionals, expert panel consisting of patients, commissioners, and clinicians, evidence-based interventions, which were widely used, and theory guided by current ideas about influences on behavior and outlining key barriers and enablers to performing behavior. Now, this was embedded within established interventions. In this study, some behavior change techniques were used, which included persuasive messaging, peer comparison, and then went on even to reinforcement. And we could see that in the example of the behavior change wheel. They carried out a rigorous real-world trial. So the team, they put their implementation package to the toughest test by doing a pair of randomized trials. They used opt-out recruitment of practices to help ensure that their practices were as typical as possible, and not only those interested in research. They used routinely collected anonymized patient data for up to 11 months to assess outcomes. They used quite a sophisticated design to ensure that they had multiple controls and could therefore be more confident that any effects they found were because of the implementation package, and not only because practices might know they were taking part in an experiment. They also did an economic evaluation to assess value for money. They did a process evaluation. So what worked? Based on this example, you would imagine not the diabetes control, call it indicator, not even the blood pressure control, not the anticoagulation in atrial fibrillation. It was the risky prescribing quality indication that worked. So, based on the trials across 18,300 patients, the odds of a patient achieving outcome in an intervention practices was 18.5% lower compared with a patient with same characteristics in control practices. So what were the lessons learned? The evaluation was rigorous. Indeed, it was carried out in the real world. And as you can see, behavior is fundamental. And population impact with small cumulative changes makes a big difference. In summary, frameworks can be useful in supporting behavior change interventions, as we could see from earlier examples. Relevant theories can also be applied to evaluate the success or failure of health and care IT implementations. Again, we could see with the example of the information value chain theory. Also, using implementation toolkits involving frameworks, theories, behavior change techniques, evidence-based materials or resources does not guarantee success in real-world contexts, but can help you understand what works and what does not, and why. These are the references. Feel free to look into those papers and just to get some more in-depth knowledge. Thank you very much.